Hi, and welcome back to yet another session with Conceptual OBG. Today, we are in the second session of our newest series that is Conceptual Entrances or COBG Entrances, wherein we prepare you for all the entrances that matter at the level of your residency. So, which are those entrances? First of all, very importantly, it can be either your NEET SS or it can be your PDCET or it can be your FET or any other entrance that you are preparing for. So, in the first session that I've taken last month, we had discussed anemia in pregnancy. We had discussed around 14, 15 questions across three different types of questions. And those three different types of questions were theory based or fact based. Then there were clinical case scenario based questions or clinical vignettes, as we call it. And the third questions were the questions that have come already in the previous years, and they were the recalled questions of those papers. So today, again, across the three segments, three categories, I am going to be taking yet another session with you all. And the topic is going to be hypertensive disorders of pregnancy, a very, very important topic. So I'll be highlighting a few points in the history that are important and will make a difference to your outcome, which means your answer. So in this question, the first important part that it's a 32-year-old primi gravida at 34 weeks of gestation presents with new onset headache, visual disturbances, and right upper quadrant abdominal pain. Her BP is 164 by 112, so she falls in the category of severe preeclampsia. The laboratory investigations reveal platelets of 80,000, that is, she falls in the criteria for thrombocytopenia. Her AST and ALT, her liver transaminases are alanine and aspartate transaminases are increased, and her LDH is also increased, that is to more than 650. The serum creatinine also is seen to be rising here, and the proteinuria is of +4. The fetal ultrasound also shows that the fetus has absent end diastolic flow in the umbilical artery. What is the most appropriate initial management? So at this point of time, I can see that there is absolutely nothing that is going right for this female. Everything, including the maternal and fetal outcomes, have been hampered completely. So what is going to be my immediate next management? So the way I've always studied MCQs happens to be I rule out the negatives and then I zero down upon my final answer. So in this scenario, what do I do next? But before I go there, I'll first discuss a few concepts about how is preeclampsia diagnosed and what are the recent most guidelines about it. Now there is one part wherein a lot of people still have doubts, and when I say they have doubts, the doubts are more so about what is the diagnostic criteria for severe preeclampsia. So, or even preeclampsia, what is the diagnostic criteria? So, over here, I've put up a picture that will help you understand this better. In this, you can see now this screenshot that you can see happens to be from 2025 AHA, that is American Heart Association, and ACA, that is American Cardiology Association. American Cardiology Association, the guidelines are from there. So, very recent 2025 guidelines. So, what do they say? First of all, that you have to have you have to see these two important words. One is and over here you can see or. So the first definite criteria is that either of the following. What is that either? Either your systolic blood pressure and or diastolic pressure has to be more than 90. So 140, 90. It is not both of them. Even if one of them is more, then it fits your blood pressure criteria. Your blood pressure criteria is either systolic blood pressure more than 140 or diastolic pressure more than 90. It is not necessary that both have to be concomitantly raised. And the most important point here is that it is not, you already know this, but you have to again remember this, that it is not merely based on the fact that it has to be raised once, it has to be raised twice, 4 hours apart, and that should be after 20 weeks of gestation in a woman with a previously normal blood pressure. So basically, she should not be a chronic hypertensive. So at this point, I've learned three important points. First of all is more than 20 weeks, of course. Secondly, twice I have to take measurements, and those two measurements have to be more than 4 hours apart. And third, and the most important, is either systolic blood pressure more than 140 or diastolic pressure more than 90. It can even be both of them together. The next criteria is systolic blood pressure more than 160 or diastolic pressure more than 110, which in fact will place her under the criteria of severe preeclampsia, whereas this was just preeclampsia. But this is only the blood pressure criteria. So along with that, I have to now take either proteinuria or the other criteria. Now in proteinuria, what is the criteria? There are three ways in which I can determine proteinuria. Now one of the first questions is that, is proteinuria a necessity for your diagnosis of preeclampsia? A lot of people in their exams tend to just say that blood pressure, raised blood pressure or hypertension with proteinuria is preeclampsia. If there is no proteinuria, it is only gestational hypertension. Absolutely not. Remember, that proteinuria is one of the types of organ damages, but there are other organ damages as well. So if you do not have proteinuria, it doesn't mean that the other organs may not be damaged. Hence, you have to take into consideration that raised blood pressure with any other organ damage will also be preeclampsia. In fact, if there is end organ damage, significant end organ damage, you will call it severe preeclampsia. But remember, proteinuria is not a must. It is one of the criteria. Then you would ask me, then why so much of focus on proteinuria? Because it is the only marker that you can measure in the outpatient department. Because see, you cannot measure your thrombocytopenia, that is your CBC. It will take a machine for the report to come to you. For it will take some machine, it will take some resources. So if you're sitting in a PHC, in a primary healthcare center, you do not have a CBC machine. You do not have that machine which runs your CBC investigation. So you will never know about thrombocytopenia. Similarly, with creatinine, you will need a proper reagent and a machine to give you the answers. Same goes for transaminases and all other things. But proteinuria can be diagnosed while you're just sitting at your outpatient department on your table. You can diagnose it very well, very easily over there. How? There are multiple ways. You can either use a dipstick, that is just a stick that you put inside, or you can use sulfosalicylic acid or nitrazine. Basically, all these nitric acid, all these basically things you have to just add it to that sample of urine, and you would be able to know whether it is proteinuria or not. Hence, because of the ease of diagnosis, is why proteinuria is considered to be an easy investigation to diagnose. But what are the various ways in which I can measure proteinuria? One of them, as I just mentioned, is already dipstick value. Now remember that the dipstick value is plus 2 or more. A lot of people ask me, what if it is trace? What if it is plus 1? No. Plus 1 and trace are not considered to be diagnostic criteria, and this has changed after 2013, 2014. A lot of older guidelines, and especially when I was in MBBS, in fact, when I was in MBBS, also this change had come, but still, a lot of people were practicing the earlier guidelines which said plus 1 or more. No. Remember that in pregnancy, you have to remember there is going to be physiological proteinuria because your GFR, glomerular filtration rate, is increasing, which is why a bit of proteinuria does occur. But it has to be significant enough to be called as significant proteinuria for your diagnosis of preeclampsia, and that happens to be plus 2 or more. So basically, plus 2, plus 3, plus 4, that is called as significant. But now there is a problem. What if that patient has just, because let's assume it is summer and your patient has just consumed a lot of water. A lot of water, matlab she has completely consumed one entire 1 liter bottle before coming to you. And when she comes to you, when she gives you the urine for your dipstick test, it turns out that her urine is so dilute because she has drank so much of water that it comes out to be only plus 1 or even trace. Now, this is the fallacy, or this is the problem of this dipstick measurement, because it will not take into consideration the urine dilution. Remember that. Similarly, let us assume the patient has come to you in the month of December, and where she has not drank water at all because it is cold outside. So she is not sweating, she is not having too many water demands for her body. At that point of time, your urine is concentrated, and that concentrated urine gives you a proteinuria of plus 2, when in fact she did not have that much of proteinuria, and hence your dipstick test will always depend on the concentration of urine. And hence it is not the best way, but it's a very convenient way, which is why it is the modality or the method that is preferred. But it is not at all the best way to know about proteinuria. Then what is the best way? The best way is only one, and that happens to be this one with green: urine protein creatinine ratio, or what we also call as UPCR. Now in UPCR, you have to remember that it is not just counting your proteins, but it is also calculating your urine creatinine. So whenever there is excessive dilution, then both your creatinine and protein excretion is going to be reduced. Whereas whenever there is concentration, urine concentration during winters, as I said, when the water consumption is low, at that point, your creatinine as well as protein excretion is going to be, or concentration is going to be much higher. And hence, they both balance each other out. It's a ratio. And hence, that is the best way to diagnose proteinuria. The best. Second best happens to be 24-hour urine protein, wherein if it is more than 300 milligram across 24 hours, then it is said to be significant proteinuria. But there are a few problems. First of all, it is very difficult and socially not great a thing to be collecting urine for the entirety of 24 hours. People may not find it good. People may find it embarrassing to be collecting urine for 24 hours. Secondly, the reason I called it the second best test is, let us assume that you have started doing a test at 8 a.m. today and you'll be finishing it at 8 a.m. tomorrow morning. But what if at 7 a.m. today you have already had a lot of water, and hence the first urine sample that you pass in that 8 a.m. Sample or in that 8 a.m. bottle happens to be a very dilute urine. Similarly, next morning, what if you have already consumed water at 7:30 a.m. when the test is about to end, when the duration testing period is about to end, but you do not pass urine before 8 a.m. and you pass the urine after the test is done and you do not collect it. So basically, depending on your pre-testing, I mean, when before uh, pre-collection phase, depending on how much of water you are taking in, it is going to be slightly affected. And hence, it is the second best way, and the best way is always going to be your urine protein creatinine ratio. And remember, this is not the only criteria. If your proteinuria is absent, you still have to go ahead and check for other end organ damages, like first of all, it is thrombocytopenia. Next is reduced kidney function. By the way, thrombocytopenia is platelets below 1 lakh, or reduced kidney function, that is your creatinine more than 1.1 or twice of baseline, or your impaired hepatic function, that is your transaminase, your SGOTPT or AST, ALT more than twice of the upper normal limit. So upper normal limit happens to be 35. So if they are more than 70, it is going to be called as significant hepatic damage. And next is going to be pulmonary edema. You have to auscultate the chest and try to find if there is pulmonary edema. Now recently in the place where I practice, we had a patient wherein the only and only thing that she had which suggested preeclampsia was pulmonary edema. She had absolutely no proteinuria. She had none other end organ damages, and all she had was pulmonary edema. And the place where she was referred from, they were treating her pulmonary edema thinking that it is some LRTI or probably some cardiogenic heart failure that she is in, but no. Her BP was 140/90 and she had pulmonary edema. People didn't even think that at 140/90 the patient can have pulmonary edema because of preeclampsia. And hence, the only thing that that female needed was termination of pregnancy followed by delivery. Basically, the delivery which is going to improve her condition, which it eventually did. And lastly, new onset headache, non-responsive to medications or visual symptoms. So basically, pre-monitor symptoms have to be present, which our patient does have. She does have visual disturbances. She also has headache. So technically, she fits into the criteria, very well into the criteria of severe preeclampsia, not just preeclampsia, but severe preeclampsia. But the points to be taken home from this discussion is blood pressure plus either proteinuria or any other end damage, not necessarily only proteinuria. Always remember that. So, at this point of time, what do I do? At this point of time, I already know that she is fitting all the criteria that are required for end organ damage. What are all the criteria? She is having new onset headache. She is having visual disturbances. She is also having right upper hypochondroplasia. Possibly she may have a hematoma inside the liver capsule. Possibly I would want to do a USG and check that. 160, 112, basically severe preeclampsia confirmed. Platelets, thrombocytopenia, AST, ALT, or liver dysfunction is there. LDH, the upper normal limits are 600. If it is more than 600, I'll be coming to that. I'll be coming to HELP syndrome after this. Is more than 650. So technically, this patient is actually having HELP syndrome. Her creatinine is more than 1.1, and she also has significant proteinuria, which is +4. She has absent end diastolic flow at 34 weeks of gestation, but at this point, I do not care. Even if it would have been a normal fetus, Or if it would have been 28 weeks with absent and diastolic flow, I would have not waited for a minute more. I would have delivered her. But not just delivery, also have to. She has not yet convulsed, she has not yet had eclampsia. So I will have also ensured that I give her a drug called as magnesium sulfate. We'll be coming to it, the way of action, the mechanism of action, everything. So I would get her blood pressure down. So basically, I will stabilize her BP. I will give her magnesium sulfate so that she doesn't have eclampsia, and I will plan delivery immediately. Right now, that fetal status doesn't matter. So even if in your question it was given that the Doppler is normal, or if it would have been given that she is 28 or 30 weeks of gestation with normal Doppler, it doesn't matter. The Doppler at this point for a female, let it be 24 weeks or 40 weeks or anything in between, you have to deliver. The fetal life doesn't matter anymore at this point for this female. Go and save your mother. Your mother is going to be the most important patient for you at this point. And hence, the answer is going to be initiate magnesium sulfate, control blood pressure with IV labetalol, and then plan prompt delivery. You would ask me plan prompt delivery, what should be the modality of delivery? Your preference is going to be for vaginal delivery. You would ask me why. You will ask me, excuse me. You would ask me why vaginal delivery and why not cesarean section? Isn't cesarean section going to quickly deliver the baby? Remember that, okay, we'll just come to this concept in the next question, the subsequent question. Don't worry, we'll come to it. Very interesting concept. Why vaginal delivery and why not cesarean section for this female? Very important. All about pathophysiology. I'll come to it in the next question. So for now, this is the question, and your answer is option A. Now, this is a question, the first question in the hypertensive chapter from our book. All the questions that you're seeing now are screenshots. You can see it's a screenshot from our book, which has been meticulously authored by me and our team at Conceptual OBG, and you would get a lot of these questions. The format of the answer that we have given is we just don't give the answer, we also give the explanation. We give every single explanation, and we also mention what is the source so that you get to know where have we taken this question from. So this is from Williams, the latest edition of Williams. Apart from that, the nice guidelines are the guidelines that the RCOG, that is Royal College of Obstetricians and Gynecologists, do follow. And we have also taken into consideration the ACOG practice bulletin. You can see the ACOG practice bulletin, which is the latest 2020 edition, and FIGO recommendations from hypertensive disorders in pregnancy 2021 edition. And I have, of course, shown you the diagnostic criteria from 2025 American Heart Association and ACC, um, American Cardiology Guidelines. I have shown you. So basically, we have combined all the best resources for you and summarized them through this question and all other questions that will be following after this. I hope you all have understood. If any doubt, please let me know in the chat. I'll be answering them immediately. If there is any doubt, do let me know. If there are any doubts, please let me know in the chat. I'll be answering them. If not, this is it from Dr. Aditya. We have a total of over 50 to 60 such sessions that we have planned, that we have lined up for your entrance preparation. And of course, the books, the online questions, everything. It's a huge question bank, and that is in addition to our core OBGY subjects that we already have, the lectures that we already have. All of this only for your premium subscribers, only exclusively for premium subscribers. So do look at the plans and do subscribe. This is Dr. Aditya signing off from Conceptual OBG for tonight. I'll see you again next week in yet another session. Until then, this is Dr. Aditya taking a leave. Good night.